Hello. Okay, today our topic of discussion will be on encopresis in children. This is also called swelling. This is a condition where a child passes stool in inappropriate places and it is often involuntary. So today we'll discuss on the definition of encopresis, then see the causes and different types of encopresis, its clinical features, diagnosis and management. The definition of encopresis is repeated passing of stool in inappropriate places in children over 4 years without organic anorectal disease. And this is often linked to chronic constipation and behavioral issues. Involuntary functional fecal incontinence is seen in this condition. The types of encopresis. It can be retentive encopresis, which is more commonly seen, and non-retentive encopresis, which is less common. So retentive encopresis is mainly due to chronic constipation and stool withholding. There is passage of painful hard stool and there is rectal distension, which leads to overflow fecal incontinence and the swelling occurs. And in non-retentive encopresis, there is no functional constipation or fecal retention. Here defecation is inappropriate and it is occurring in inappropriate places over a month. And this is linked to psychosocial or behavioral problems. If there are any emotional conditions happening in child's life, any changes in emotional trauma, so anything the child is not being able to adjust. So if these things are happening, then the child starts getting encopresis. So these are different two types, but more common is retentive encopresis. Now come to causes of encopresis. So usually encopresis is caused by chronic constipation. So this is more common cause. So chronic constipation occurs where the child is passing hard, painful stool. Because of the pain, the child avoids defecation. So stool builds up and then stretches the colon. All the impacted stool stretches the colon and liquid stool leaks around the impacted stool without child's control. So involuntarily the child starts soiling the underwear or the clothings. This is the more common cause. And some other causes which can also contribute to encopresis is inadequate toilet training, low fibers and fluid intake, emotional and psychosocial stresses which may occur in school or in family, and certain neurodevelopmental disorders like attention deficit hyperactive disorder and autism. So these two conditions may also lead to encopresis. So these two conditions I will be discussing in my following next two classes. Clinical features of encopresis is there is hard stools which is passed in inappropriate locations. There is underwear swelling from the fecal incontinence. There might be large infrequent bowel movements. There is abdominal pain and sometimes even distension, and because of that there is decreased appetite. Child has a habit of withholding the stool, so they stand cross-legged and then try to hide to avoid defecation. So they are having the pain like this and then they are crossing their leg to avoid defecation because they are scared it is painful. Now come to diagnosis. So main diagnosis is by history and physical examination. The investigation does not have much role or much of the investigations are not required. But sometimes abdominal X-ray can be done just to see the or to assess the fecal loading of the colon, how much it is loaded with the colon is loaded with the stool. Otherwise, routinely this is not recommended. Some additional imaging can be done like spine X-ray or MRI if you suspect spinal abnormalities in the child. And sometimes further diagnostic investigations may be required to rule out other differential diagnoses, that some other conditions where constipation can be there which leads to encopresis. So conditions like hypothyroidism, if you suspect, you do the thyroid function test. Celiac disease, if you suspect, then do the further test. Milk intolerance. And then another is use Rome 4 criteria to diagnose functional constipation accurately. Best is to follow this criteria, which I'll be discussing in my next slide. Then anorectal manometry for evaluating anorectal function can also be done. Okay, let's see the Rome 4 criteria for functional constipation in children. So if you follow this criteria, you can diagnose chronic constipation accurately. So according to this criteria, there must be, or it must include 2 or more than 2 of the following points, which should occur at least once per week for at least 1 month. So if it is occurring once per week for at least 1 month, then you can say this is chronic constipation, and out of these 6, 2 or more than 2 points should be present. So in children 4 or more than 4 years old who are toilet trained, the criteria are: number 1, 2 or fewer defecation per week; number 2, at least 1 episode of fecal incontinence per week; number 3, history of retentive posturing or excessive violation stool retention; number 4, history of painful or hard bowel movements; number 5, presence of large fecal mass in the rectum; number 6, history of large diameter stool that may obstruct the toilet. And Rome criteria for children less than 4 years who are not toilet trained: number 1 criteria, 2 or fewer defecation per week; number 2, history of excessive stool retention; number 3, history of painful and hard bowel movements; number 4, history of large diameter stool; number 5, presence of large fecal mass in the rectum. So out of all these, 2 or more than 2 points should be there, which should last at least once per week, and then at least, which should occur at least once per week and last at least 1 month. Then only you can say this is a functional constipation. Now come to the management part, which is important. So in the management part, step 1 or main is education and support. You have to give reassurance to the parents and the child that this is an involuntary condition and it is manageable if they follow the behavioral therapy properly. Number 2, disimpaction is done because the stool is all loaded with a constipated hard stool. So here you give oral polyethylene glycol, or also known as PEG, or rectal enemas in severe cases to clear up the fecal mass so that all the hard stools will come out. After that, you give, on the step 3, you give maintenance therapy. That is, we continue the osmotic laxatives, either PEG or lactulose you can give, to promote regular bowel movements. So this maintenance therapy is continued for around 4 to 6 weeks depending upon the condition. So there is a regular bowel movements. So along with that, at step 4, some stool softening conditions or techniques should be applied. That is, increase the fiber intake in the child and then increase the fluid hydration. So plenty of fluid and fiber intake is suggested to the child so that the bowel habit becomes regular. Then there are some behavioral therapies. The very good behavioral therapy is just make a scheduled toilet for child. So make the child sit in the toilet for 5 to 10 minutes whether the stool is coming or not. Especially you can do this after meal, and then try positive reinforcement. That is, you give reward if the child is passing stool that time. So this way the child will have a habit of passing stool when the child is sitting in the toilet in the especially you can do this in the same time, so that the child develops a habit of sitting in the toilet. Other training guidelines is start toilet training a child at 2 years of age. So by 2 years the child should be trained, otherwise the child will not develop the habit, and they have a habit of standing and passing the stool. So many children, if you see, they don't want to sit in the toilet. So this habit of sitting is very, very important. So they try to stand and pass the stool, so which aggravates the condition, because that force is not enough also to push the stool. So the child is not improving. So this toilet training, if you start at 2 years, it is very effective. And always avoid punishment. Don't punish the child, because the child is not doing it voluntarily. It is an involuntary condition. Then you give psychosocial support. Try to address the emotional or behavioral issues. If the child is having, just try to find out the cause for these emotional conditions and then the behavioral patterns, and you can try to correct those. And now come to some nutrition or the diets recommended for the child having encopresis. They should get a balanced diet which is rich in fruits and vegetables. Green leafy vegetables are very helpful, and whole grains. So many times the child can take fruits with the cover, wash properly, but take fruits like apple with the cover, don't peel the cover. So that way, if they take in the vegetables also, carrot and then the cucumbers, they can take with the cover without peeling. So that adds the fiber in the diet. Then fiber intake should be recommended. They should be taking adequate dietary fibers to prevent the constipation, and just recommend them plenty of fluid. Encourage them to take a lot of fluid which softens the stool. So this way you can correct the encopresis, correct the constipation, and then ultimately correct the encopresis. Prognosis: with proper treatment and follow-up, maximum children they improve. But if the behavioral modification and then therapy is inconsistent, then recurrence is common. Chances of recurrence is high if you are not following the behavioral therapy properly. And always counseling and positive reinforcement. These two are very important point for the good prognosis of a child with encopresis. Okay, thank you. Next class I'll come with another topic. Thank you.